Some of the hips will use what we call a hemovac drain, which is like an accordion type drain that you push together, and that's removed at the bedside by the surgeon on the second post-op day. Okay? The other drain, typically for the knees, it's called a Constavac, and this is a complete closed system put in by the surgeon, date and timed in surgery, and the nurses have 6 hours to reinfuse your own blood loss, okay? So that really helps to maybe not need a blood transfusion. After you have a total hip or knee, sometimes there's a need for that because, you know, our blood is made in our bones, and we do lose quite a bit during that procedure. So technology has come so far that we're losing very minimal amount of blood now, so it's not as big of an ordeal as it used to be, but we still take those precautions, insert a drain, and those are, we don't need the consent for that. You're not going to have any reaction to it. It's your own blood loss that's there that's going to be put back in.
Another thing we want to help prevent here in the hospital after surgery is what we call post-op pneumonia. And one of the easiest things to do that is to use this thing. All right, we call this an IS or an incentive spirometer. It has 2 toggles. There's a yellow toggle here that you're going to try, and it's labeled good, better, and best. So you're going to try and inhale through this straw. You're going to try and let this yellow toggle float in the best section, at the same time getting this white toggle as high as you can get it. Okay, so I'm going to demonstrate. You're going to, Janna likes to say this is, think of this as your
big, thick milkshake. So, whatever flavor you'd like. Big, thick milkshake. And if you think of that when we've got you laying in bed and you've got your pain medicine on board, and then your nurse hands you this and asks you to do something with it, the first thing everybody wants to do is what? Blow in it. Just blow in it. But that's not the body mechanics. And if you understand what you're doing with that, then you know you will use this. So what happens is we give you a lot of extra fluids during your surgery, and then we fill you with the pain medicine, lay you in bed, and then where are you breathing? You're breathing right here. You're not emptying or exchanging the gases down here in the bottom lobes of your lungs, and this is going to help you do that. This can single-handedly keep you out of post-op pneumonia if you use it faithfully. But the body mechanics is, if I blow, what am I doing? Look at my body. I'm closing off. It's not doing what I know that I'm supposed to be doing. But if I inhale, you can see how his whole body changes. And that's exactly what you want to happen. You want to exchange the gases down there, and that's where the fluid puddles, it hangs out down there. So you have to bring it out. Sometimes that'll stimulate a cough. I've gone into patients' rooms and says, oh, your incentive spirometer's way over here. Let me get that for you. And they're like, oh, no, that makes me cough. That might happen. That's good because it's bringing it out, and you want to get rid of it. You want to bring that out. Okay? If that puddle's in there, and just even 24 to 48 hours, you can have a fever. So this can keep you from that. Very important tool here. This is something I just wanted to add in. When you're on the pain pump and you come up to our floor, you have a nasal cannula. Has anybody ever used that or had surgery? It's for oxygen, and you probably have seen it on TV. It goes in and just kind of sits right here onto your nose, and it looks like that. I don't know, can you see those 2 little prongs there? The thing that we have new, that when you come up after surgery, after our total joint surgery, we're using a machine that's also not only delivering you the oxygen, but it's also counting your respirations, because you're going to be on your pain pump. You know, you're going to be kind of sedated there. It's IV medicine, and this fits down kind of right here on your upper lip, like a little mustache there. So that will come off rather quickly. You'll do about 24 hours with that, and once you are alert and we know that you are coming around, you know, and breathing deeply and clearly and using your IS and all of that, and everything's working beautifully, we change this out to just the cannula or take the whole thing off for room air.
So going into the next day after surgery. So we call this day post-op day 1. We count days after surgery, so post-op day 1, this is when physical therapy starts. Going back to your question, yes, you will be getting up the first day after surgery. The doctors order it for you. I wouldn't be there if the doctor didn't want me to get you up and moving. I get a lot of that. When I come in the room, people always say, but I just had surgery yesterday. Well, the doctor wants you up and moving because there's a lot of complications. We've already talked about DVTs. We can help reduce the risk by getting you up and moving. We've already talked about post-op pneumonia. We can also reduce the risk of post-op pneumonia by getting you up out of the bed and moving you around. All right? And we can also help decrease the risk of bed sores by getting you up out of that bed. All right? You already guys know what exercise number 1 is. Exercise number 1, if you remember, I want you pumping your feet up and down after surgery. That's going to circulate that blood. All right? Number 2 is what we call, and I've included all these exercises in your packets, is what we call a quadriceps set. These 4 thigh muscles, there's 4 of them. They're called quads for short. What I want you to do is they control your knee. So especially with the knee patients, you're going to find that these muscles are very weak after surgery, and we got to wake them up by using them. I just want you to tighten those muscles up, get those muscles nice and tight, and then relax. We're going to wake those muscles up, and we're going to remind them what their job is. Number 3 on the list is what we call gluteal sets. Gluteal muscles are your cheeks. So what you're going to do is you're going to clench your cheeks together, your buttocks cheeks together. You're going to hold for 5 seconds, and then you're going to relax. Because those are some of the biggest muscles in your body, and if you can get those muscles contracting, you're pushing a lot of blood. And when you're pushing a lot of blood, you're also helping to reduce that risk of DVTs, okay, blood clots. Number, what is that, 4 on the list? I'm going to be doing heel slides with you. So for our knee patients, the CPM, that machine that bends and straightens your leg, that is what we call a passive exercise. It does it for you. But by doing the exercise, I'm going to be holding onto your leg, and I'm going to get you to use your muscles to bend and straighten your leg. Okay, so that's how we get the muscles involved with the exercises. All right, so we'll be doing about 10 of those at a time, heel slides, relaxing, and as you guys get stronger and as that gets easier, we're just going to be adding sets. So usually sets of 10. All right, so those are heel slides. For our knee patients, we'll also be doing straight leg raises. So I'm just going to help you lift and lower your leg in the bed. All right, sets of 10 as well. And this exercise is actually going to help you get out of the bed because your leg, you're going to find your leg will be weak, and if we can get those muscles nice and strong again, you'll be able to lift that leg up out of the bed. All right. For our hip patients, I'll help you hold the leg, and we're going to be doing what we call abduction. So we'll be going in and out with your surgical leg. And we won't be crossing midline because remember, one of your precautions is no crossing. So I'll just be bringing you about to midline and bringing you back out. And we're doing all these exercises just to help stimulate those muscles, wake them up again, get them nice and strong again. So you guys can walk, we want to wean you from the walker, and we just want to get you walking without pain. I'm going to go over this walker. I will start with a rolling walker. I see Mr. has what we call a standard walker. But the therapist, if you prefer that when you're in the hospital, we do have standard walkers here. We can use those. But a lot of times therapists, we like to use these ones with wheels. A lot of people are afraid of the wheels because they think it's going to roll away from you when you're walking. But I can put my whole weight on here, and it's not going to roll away. As long as I'm putting some weight on the backs, those backs act as brakes. We'll use a walker because it's going to give you a lot of support. I'll have a safety belt around you, so I'm going to put it around your waist, and it just gives me something to hold on to you with. If you start to lose your balance, me and my partner are going to have our hands on the belt to help steady you if you start to lose your balance, okay? But what the rolling walker does is, let's say, again, my surgical leg is my left leg. Most total hips, total knees, the doctors allow you to put your full weight on your leg after surgery. It's going to be what we call weight bearing is tolerated. It's going to be up to your pain level, really. So you can baby that leg as much as you need to as well. But when you walk with a walker, you push the walker out in front of you. You're going to step with your surgical leg. And when you want to move your good leg, if you need to baby this left leg, you're going to put your weight on your arms. So at first, the walking is going to be kind of like this, kind of broken up. But why therapists like the rolling walker is because we can then advance you to what we call a more normal gait pattern, where you can push this walker just like a shopping cart and just lean on it the whole time, and it still gives you support. Okay? So it's always walker, surgical leg, non-surgical leg. All right, and then eventually we'd like to wean you from one of these and then get you walking to nothing. Okay? All right, so that's the rolling walker. So I'll be doing the exercises with you the first day after surgery. I'll be getting you up and walking, and then I'll be getting you sitting in the chair. I'd like to get people up in the chair for at least 45 minutes to an hour, because if you think of it, you guys aren't sick right now. You'll be injured after surgery, but you're not sick. If we leave you in that bed for 23, 24 hours of the day, then it's a good chance we may make you sick. So just by getting you out of the bed, we're going to be preventing a lot of complications here. All right, the average stay here in the hospital is 2 to 4 days post-operatively. First day after surgery, physical therapy starts. I'll come talk to you. I'll help evaluate you to see how well you guys are doing with moving around. One of our biggest goals is to get you home. Okay, everyone wants to be home. But if it's taking 2 to 3 of us to get you up out of that bed on that first day, home might not be the best thing for you. It may not be the safest thing. All right, so after I help evaluate you, Laurel's going to come talk to you. She'll read my evaluation. She'll see how well you guys did with therapy, and she'll help set up any post-discharge arrangements that you'll need.